Okay, well, bienvenidos and welcome to everyone. Thank you for joining us today. I'm Dr. Valerie Romero-Leggett, Vice Chancellor for Diversity, Equity, and Inclusion, and Professor in Family and Community Medicine at the University of New Mexico Health Sciences Center. And I have the distinct pleasure and honor of being today's moderator for this informative and exciting session. Next. From those from the University of Arizona, in order to receive CME credit for today's session, we want you to use this QR code or the link that's shown here, and the link will also be placed in the chat. And then for all of you who have joined today, as questions come up throughout the session, please just place them in the chat. Next. So this webinar is a collaborative effort between the diversity, equity, and inclusion entities at the academic health centers at the University of Arizona, the University of New Mexico, the University of Colorado, the University of Utah, and the University of Nevada, Reno, known as the Southwest DEI Collaborative. And today is part 2 in our 2-part series addressing COVID-19 disparities and vaccine hesitancy, moving toward health equity. Now, during part 1, we heard from our distinguished panelists and had a robust question and answer session as they laid the groundwork in describing disparities and vaccine hesitancies in our underserved populations. And today, we'll be discussing strategies to address these disparities and vaccine hesitancy in specific populations, institutions, and communities. Next. We'll begin today's webinar hearing from our renowned panelists. And then in our final half hour, our esteemed colleagues from our Southwest DEI Collaborative will join the panelists in an open question and answer. So please join me in welcoming our esteemed panelists, and I'll give a brief little bio on each of them, and then we'll start our webinar session today. So Dr. Joshua Lee is Physician Executive with Banner University Medical Group and Associate Professor of Medicine at University of Arizona College of Medicine, Tucson. Dr. Lee oversees the faculty practice at the University of Arizona Banner Health and is responsible for the clinical program development on behalf of the health system. He's a practicing general internist with a background primarily in clinical informatics and data warehousing, and has had a long-held interest in marginalized populations in healthcare. He is a native Californian and very happy to be returning to the Southwest after his stint as CMO I think in California, I believe. No, it was in Chicago. Thank you. And welcome back to the Southwest, Dr. Lee. Dr. Gail Tenay-Chacon is professor and founder of the Center for Native American Health at the University of New Mexico Health Sciences Center, and currently executive director of the Native American Budget and Policy Institute. She's also an associate physician in the Division of Global Health Equity at Brigham and Women's Hospital. Dr. Tenay-Chacon is from the Navajo Nation and is a grandmother. She served as Surgeon General for the Navajo Nation and was a member of the Advisory Council for the Office of Minority Health in the U.S. Department of Health and Human Services. As the executive director of the Native American Budget and Policy Institute, she analyzes research and budget policies in areas of health, education, and environmental justice for our Native children, families, and communities. Dr. Amira Delfino Jones is an associate professor in medicine, Division of Hospital Medicine at the University of Colorado on Chiefs Medical Campus. She is Director of Diversity, Equity, and Inclusion for the Division of Hospital Medicine and Assistant Program Director for Diversity and Inclusion in the Internal Medicine Residency Program. And as Director of several pipeline programs geared towards underrepresented undergraduate students interested in health careers, Dr. Delfino Jones is dedicated to diversifying the healthcare workforce in an effort to improve the quality of care for all patient populations. Dr. Ricardo Correa is an associate professor of medicine and program director for endocrinology, diabetes, and metabolism in the University of Arizona College of Medicine, Phoenix, and director for diversity and inclusion for graduate medical education. He completed his medical school and education master's at the University of Panama and a research fellowship in epidemiology and tropical diseases at ICGES in Panama City. In 2012, he was honored with the AOA and Gold Doc Award from University of Miami. He is author of the book titled Case Report Basics and Publication and senior co-editor of the book Endocrinology of Aging. And his research is focused on neuroendocrinology, mainly pituitary and adrenal tumor, and healthcare disparities in diabetes in Latinx populations. Dr. Nicole Jacobs is Associate Dean for Diversity and Inclusion at the University of Nevada, Reno School of Medicine, and the Western Region Representative to the AAMC Group on Diversity and Inclusion. She leads an implicit bias research group focusing on assessing and mitigating implicit bias in medical students and members of search and admissions committees. Dr. Francisco Moreno is a tenured professor of psychiatry at the University of Arizona Colleges of Medicine, Tucson and Phoenix, and Associate Vice President at the University of Arizona Health Sciences for Equity, Diversity, and Inclusion. In this role, he works to increase diversity of the health professions workforce and increase the cultural proficiency and community congruence of health services and research to address Arizona's health priorities and decrease health disparities. As part of his academic efforts, he serves as multiple principal investigator for several NIH and HRSA grants addressing these vital issues. So please join me today in welcoming this esteemed group of panelists, and we will begin now with Dr. Lee. Thank you.
Thank you so much, Dr. Romero. So we were going to start with a little bit of setting the table to understand the rural disparities in the pandemic, and particularly focus on the state of Arizona. On the next slide. What I'm hoping to demonstrate today is that both the infectivity rates and the death rates are really different in the state of Arizona between urban and rural counties. And that's unique here, and we've been closely tracking throughout the pandemic on a daily basis the report not only of the tests performed, but the test positivity rates, the case counts, and sadly also the death rates in these particular counties. In the state of Arizona, the vast majority of the population lives in two central semi-urban counties. Those are the counties of Maricopa and Pima. We in Tucson live in Pima County, whereas around the periphery of the state, and particularly in the Northwest, it's sparsely populated, and in the Northwest in particular, in the counties of Navajo and Apache, there is a very large indigenous peoples population in that area. On the next slide. So here's an example of a baseline of what Pima looks like. So Pima County in total, this number's up a little bit now. This was already as cases were coming down, really 106,000 total cases. But in the rate of cases per 100,000 population, we're really roughly in the 10,000 per 100, so like a 10% case rate. And the fatalities per 100,000 is 198, which admittedly is large, but we'll see on the next slide is even higher in those other counties. So if we go one more slide, here's a comparator of Apache County, which is very much in the northwest corner. Apache County is a particularly complicated situation as tribes extend across the borders between the states of Arizona and New Mexico, and healthcare is often apportioned between the two. So you can already see right off the bat, it's nearly 150% higher in the number of cases per 100,000 and nearly 200% higher or 250% higher in the rate of fatalities per 100,000 population. And those of us who have been monitoring this from the very early days of the pandemic saw these early, very significant spikes in cases in both Apache County and its neighbor, Navajo County. And this led actually to a lot of patients being transported to our Banner Health facilities, both in Phoenix, but even patients came to here in Tucson. And finally, on the next slide, really, what are the drivers of this differential? I think one of the questions is difference of housing density, not density in loci of housing per square acre, but rather the number of generations and people who live in any given house. This echoes things that we learned about in our first talk a few weeks ago. But I also want to highlight the markedly different access to care. And as has been proven throughout the pandemic, rapid referral to high volume centers was a clear driver of survival in COVID pneumonia and in COVID illness in general. And the absence of tertiary care facilities really, I think, makes a difference. The closest, for example, in Apache County is really in Coconina County, in Flagstaff, and even that doesn't have the volume or expertise as in Phoenix or Tucson. I think people who also know these more peripheral counties know there's a markedly different utility and water sewage provision, which makes hand hygiene much more difficult. And then lastly, as we talked about last time and we'll talk about again, I think there's a very different set of trust in healthcare structures, and we're going to return to this theme later. But here I just wanted to kind of lay out, and a lot of us in the state of Arizona are concerned that this gap, this delta of basically not only morbidity and mortality will only widen if we don't take proactive steps to address the potential vaccine gap, which would only worsen this. So thank you very much.
Good afternoon, everyone. Thank you, Dr. Romero-Leggett, and thank you, everyone, for giving me this opportunity to give a general overview of vaccine hesitancy in the American Indian population. I'm originally from Chinle, Arizona, which was the epicenter of COVID-19 cases on the Navajo Nation and in Arizona back in May of 2020, as you just heard from Dr. Lee. Next slide. I also think it's important to just kind of give a general overview of the status of American Indian Alaska Native, which you hear a lot of, especially the term used in population demographics and as a racial ethnic group, and especially as it pertains to racial and ethnic health disparities. But Pueblos, tribes, and nations have inherent sovereign rights and a political relationship through treaties with the US government. So we have a government-to-government relationship that does not derive from race or ethnicity. This political status of inherent sovereign rights is long established and even in the Constitution. So these rights we have treaties that are in exchange for our land, and we are offered health, safety, and welfare for our tribal members on tribal land. And this also includes public health authority for our tribal nations. And next slide. I just want to also emphasize that tribal collaboration and consultation is very important when it comes to dealing with this pandemic. So the vaccine trials on Navajo Nation, you heard early in the pandemic that Navajo Nation had the highest infection rate per capita. In May 2020, the 2,300 cases per 100,000 were on Navajo Nation, while in New York, it was about 1,800 cases per 100,000. And we were hearing about the crisis happening in May in New York, and at the same time in Navajo, it was much higher. In August 2020, Navajo Nation IRB expeditiously approved the Johns Hopkins Center for American Indian Health Pfizer BioNTech vaccine trials on the Navajo Nation. And they also, Johns Hopkins was conducting trials with the White Mountain Apache Nation in Arizona. This certainly did not go without concern, especially where I'm from in Chinle. You know, many of my family members were concerned that once again, we're being used as guinea pigs. And we often hear that term just because of this history of distrust. And as you may or may not know, the Havasupai tribe sued Arizona State University back in 2004 for lack of informed consent, violation of civil rights, and negligent infliction of emotional distress, where ASU was doing research with this tribe and obtained blood samples, which they then subsequently used without consent on genetic studies of the tribe. And when this was found out, Havasupai then sued ASU. Navajo Nation also then, as a result, established a moratorium on genetics research for Navajo Nation, and that still exists today. We heard during our last part 1 of this series, the history of forced sterilization in Native women from IHS. So there's this long history of distrust and failed policies that you can also look up other examples. Next slide. Here is a billboard in Mesa, Arizona by the Havasupai tribe stating scientific exploration should not be tribal exploitation. Next slide. This vaccine rollout, as I stated, tribal sovereignty, tribes had the choice of utilizing the state rollout or the Indian Health Service rollout. And many tribes, most tribes actually chose the IHS rollout, which actually has been going very well and very highly utilized. Also, tribes have the decision to prioritize who would be getting the vaccine. In the Cherokee tribe, for example, prioritized Cherokee language speakers as those who would get the first vaccine. Some tribes have a life expectancy of 60 years of age, which a 75 age cutoff is not realistic. So they chose their own age eligibility for the vaccine. And for Navajo Nation, one of the priorities was given to our religious and spiritual leaders, such as our medicine men. So it really, tribes had to, they have the priority on who should be able to get the vaccine. Native people get their health care very complicated from many different sources. So this can be a challenge. Navajo Nation, the rollout began December 15th, 2020. And so far, here are the numbers as of a few days ago. 142,607 total doses have been administered, and about 52,000 have been fully immunized. I'm not an epidemiologist, but my calculations are show that about 53% have had at least one vaccine on the Navajo Nation. And currently we are in phase 2, which means we are anyone in phase 1 who needs to get the vaccine, and it's open now to the general population on Navajo. And this, the next bullet just talks about the positive numbers of COVID cases. In the spring, as stated, was pretty high for an individual day. November, 401, and then January, a 7-day average of 233 cases. And today, the 7-day average is 14.8. So next slide. And this graph shows this, that very, the gray is 1 day total count. So that very left slide, that very left peak, the first peak is May, and that's 238 cases. That very, the second peak in November, that very high gray line is 401. And then moving over to that red, if you follow the red 7-day average, the one on the right, the highest peak on the right is a 7-day average of 233 cases. And then the very bottom on the total far right is March 3rd, and that is actually March 6th with a 14.8 average, 7-day average. And as you can see, where the vaccine rollout began, again, was in December, mid-December. Next slide. This is my mom. She was on the front page of the Arizona Republic, Galina Diniazzi, and she's in the nursing home and received her vaccine on December 18th. She looks scared. I said, Mom, you look really afraid. So next slide. So vaccine hesitancy versus acceptance. There was a survey done of over 1,400 American Indians across the US, and 75% were willing to receive the vaccine. Their overwhelming motivation was to be responsible in protecting our Native communities and preserving our culture and language. We need constant, consistent public health messaging that's culturally relevant, and our communities and tribes should be able to prioritize who gets the vaccine. Early trials leading by example. So even though we were concerned, or many of our people were concerned about being part of the early trials, it really did set an example for the community. and certainly exerting our own public health authority for our tribe and community. And in the end, taking responsibility leads to resilience. Thank you.
Hi, everyone. So during the previous webinar, I spoke about vaccine hesitancy, vaccination rates, and COVID-19 disparities amongst the African American refugee communities in Colorado. And today I was actually going to focus more on the strategies that have been used to decrease vaccine hesitancy, increase vaccination rates amongst these populations, and also reduce the healthcare disparities or the health disparities that we're seeing that's related to COVID-19 in these populations. Next slide. So at the forefront of our strategic planning for addressing vaccine hesitancy and increasing vaccination rates, we've really been focusing on targeted education for these specific communities, and I would say actually all communities in general. But as you can see here, we've had a number of open forums that have been hosted by the mayor as well as other organizations. So one specific organization, the Center for African American Health, actually holds a number of lunch and learn series in which community members can join and ask questions, hear about certain topics, including vaccinations, how vaccines are developed and things like that. And, you know, this is a perfect safe forum for people's concerns to be addressed. We've also, in terms of panels, tried to make sure that we've diversified those panels in terms of including experts that are also from diverse backgrounds. So people in the community can hear from people who come from similar backgrounds. There have also been a number of different ads and campaigns to address common concerns amongst these populations. And in addition, a number of educational pamphlets and other written materials that are, we say, culturally sensitive, culturally appropriate, and really targeted towards specific patient populations. Next slide. So I think many of us have realized, so when COVID-19 kind of first hit, if you will, we lost access to a lot of different communities, centers, specifically churches, in which people were able to gather, had a sense of community, and had you know, a lot of trust for people who were part of those communities and systems. So as we look at, you know, addressing vaccine hesitancy and increasing vaccination rates, we've really tried to, you know, increase our outreach to churches and community centers and join forces, if you will, to increase vaccination rates amongst these different patient populations or different communities. So again, you know, we've had this realization that, you know, not all of these communities have easy access to, say, our hospital or the different clinics that are administering the vaccines. And we've definitely had a number of different large vaccine events, say at sports centers and such, where people can come and get their vaccinations. But instead of having people come to us, if you will, we really said, you know, we need to go out into these communities and help provide education, as I talked about before, but also help administer these vaccinations for those who are interested. So these pictures here just show one of the vaccination events that occurred at one of the churches. And, you know, I've mentioned the community center, specifically the Center for African American Health, who also partners with a number of different locations to, again, help with education and to provide these vaccinations. You know, one other thing I did want to mention is really having to overcome this technology barrier, if you will, as well, for a number of our different populations. And in order to sign up for vaccines, some people had to download our app, for our hospital to sign up. And really sign up for a lot of these things online. And a lot of people don't have access to this technology per se. So there has been an effort for practitioners to actually call patients and help them schedule their appointments and actually direct them to these different vaccination events that are occurring in the community as well. Next slide. As far as hospital resources, these are things that we've really been implementing in order to reduce some of those disparities that we're seeing amongst different patient populations. So specifically at the University of Colorado Hospital, there was a patient navigator project in which each patient who was admitted with COVID was assigned a case manager and someone from language services if appropriate, so a translator. And where this was most helpful, as you can imagine, is around discharge planning and education. So at the, prior to discharge, these two people would actually go see the patients, talk to them about the discharge plan, as well as the follow-up care that they were going to need after they were discharged from the hospital. And it was very helpful to have somebody there from language services to help translate, answer questions, and also talk to the families via the video chats that we have in each room as well, if necessary. And then, as I mentioned before, in terms of developing educational materials, we have a number of different handouts on COVID, including post-discharge instructions that are translated and, again, culturally appropriate for our different patient populations. And then we also had a remote patient monitoring program, which basically for patients who were diagnosed with COVID and discharged from the hospital, if they met criteria, they would get a monitor to watch their pulse ox, monitor their heart rate as well. And as soon as we saw that this was quite successful, this was quickly expanded to include non-English speaking patients as well. So again, really trying to make sure that we were targeting our more diverse, vulnerable patient populations. Next slide. And then, last but not least, from an educational and pipeline perspective, I would say the need for diversity in the healthcare field has really come to the forefront during this pandemic. And I'm not saying that this wasn't important prior to the pandemic, but it's become even more clear the importance of diversity in the medical field. As I mentioned, in terms of people administering vaccinations, sitting on panels and things like that, that has been a lot of our diverse physicians and healthcare practitioners. So once again, this is just stress the importance of the role of a diverse healthcare workforce in many things that we do in healthcare. But this particular physician, Dr. Brown, is an ER physician at the University of Colorado who has seen a number of COVID-19 patients. But interestingly, he had recently received a message or an email from a student who was just accepted into the medical school, so another African-American male. And he had mentioned that years and years ago, he actually saw Dr. Ron Brown in the emergency room. Dr. Brown had taken care of his mother. And he said he had seen him probably just for a couple of minutes, but just seeing another African-American physician is what really inspired him to stay on track to become a physician himself. So once again, I think that story speaks highly to the importance of diversity in the medical field. Next slide. And we've had a number of our physicians from underrepresented backgrounds, diverse backgrounds who have participated in different vaccination trials and such. I think just to, serve as an example to the communities that we're serving. And once again, I think it's important that people see, there's additional trust when people are able to see that people who look like them are, getting the vaccinations, able to provide education and more information on these vaccinations. So again, it's not ignoring the things that have happened in the past, not ignoring the mistrust that currently exists within or about our healthcare system for certain patient populations, but hopefully it's a step in the right direction. Thank you.
Oh, thank you so much. Now, something that I'm going to talk is very similar to the prior speakers, but I'm going to focus a little bit on Latinx population. So we can see the next slide. So this is something that was happening at the beginning of the vaccine, how I get an appointment. And the best way to get an appointment was going into the internet and having making an appointment through the internet. What is the problem with underserved communities? Underserved communities where the Latino population is very high, was that there was no access to internet. The process of getting a vaccine through the system was very difficult. It was not an easy way, and this was one big problem that we had at the beginning. Now things are getting better in different states. In Arizona now there is a phone system where you can make the appointment. But I wanted to bring this because when it was planned, probably it was planned with for certain type of population, but there was not planned for every type of population. In the next slide is the next caveat or problem that we have. You see this was in the news. Arizona was the state that started having a stadium drive-through. There was 24/7 vaccinations. It was amazing, the logistic and the work that was done. But something that you can see here is that everybody have a car. So to go to this center to get the vaccine you needed a car. And then that is another thing that was not planned for other populations that really require more need, because not everybody have access or to the internet at the beginning or to access to car. So the next slide. So then something that we published in the Arizona Republic was, don't wait for the underserved to sign in for a COVID-19 vaccines. In these communities that they like the Latinx community, you need to go to them. So you need to approach them in a community way. And this is something that I'm going to mention in the next slides. The next slide. So there are 4 strategies that I would like to mention, and then just give you some examples of what we are doing. One is build trust and prove our trustworthiness. So basically, we have to understand that the marginalized communities has been having some issues, as Dr. Delpino Jones mentioned, with the healthcare system through multiple years of mistrust. So now we have to start building that trust again, and we have to be the voice for them, and then just reach to them in a way that they can understand that we are not coming from the specifically scientific world, but we are coming also from the world that we care about them. So I always tell that, for example, for the scientific world, listening to Dr. Fauci is very impressive, and this is the majority of the things that we pay attention. But if you think about for the community, Dr. Fauci do not represent anything. So for them, it's better to trust in a physician or a healthcare worker that live in that community, that stay in that community, and that's how they will get the trust. So very important is build that trust with people that live in the community, not just relying on important national speakers in these communities. So go where they are. This is something very important. So deploying community-based teams, including community healthcare workers, door by door, giving some flyers, talking to the families. That is very important in the Latino community. People trust their neighbors. People trust their community workers. People trust their leaders, or the center where they go process. So in the next slide. So another thing is don't let this problem fester. So the Latinx population is more likely to have some other comorbidities, including obesity and diabetes, and people are more likely to live in poverty and have under insurance. I put the example here in Arizona. So it's very important that when we go to the community, besides addressing the COVID-19 we need to get something else to the community. So we have to address other problems. So when you train the community healthcare workers, also they need to be trained in these things, because they are going to ask other questions that are not only related to COVID-19. And very important to take into consideration the undocumented population that live, and then how to build that trust whenever at the beginning of the pandemic, there were some issues where ICE was in the testing centers. Now you have to change that rhetoric and say, okay, our community clinics are the ones that are going to give you the vaccine. You can go and you can trust, because this is the centers that are doing. And then definitely very important is make this vaccine equitable and transparent. So if how you are getting it, there have been some difficulties in some states, and Arizona one of them, to get it to the underrepresented population. We're trying to work on that. So next slide. So one strategy definitely is education and outreach campaign. So this is very important at every level. And I put one example that is being ongoing, and it's having a lot of impact in the middle to younger Hispanic population. It was very successful in the English community. It's called This Is Our Shot, was very successful in social media. And now with the help of them, we are using that as a Vacúnate Ya for the Latino community. With this Vacúnate Ya campaign, multiple decrease in vaccine hesitancy has happened in several states. It started in California, so we are taking that model and we're expanding that model through the entire nation. And one is that everything that we as Latino Christians do with hashtag like Vacúnate Ya, and we spread the word, and we are creating some videos, music videos, because music is very important for the Latino community. So music videos and other type of campaign to attract more people, and then also the famous Latino or artist or something to bring them that. A very good successful was in California happened. We are going to do this in Arizona. It's having an art event where local painters go and show their art.
Well, we will give Dr. Correa a moment here
During
to.
oh,
Dr. Correa, you were frozen for a moment when you were talking about some of the media. So would you like to pick up from there?
Yes. So I don't know if thank you so much, Dr. Romero. So basically what I wanted to focus is that using other techniques that helps the community is important. One of the techniques is having art events where local artists come and to the center of the vaccination, and then the people that are going to get the vaccine also have the opportunity to go and see some of the arts and interact with the artists that are the local artists. That was very successful in California, and now we are trying to apply this into Arizona. So that is a good strategy. The other things that I mentioned here in the outreach campaign is we'd only not focus on the more traditional ones, that is the TV, the social media, or the communication as with the community health workers door by door, but always also the radio. The radio is a very important way of communication for the Latino community. And there are some radio leaders that is very good to pair with them and then do some work. For example, the Vacúnate Ya program pair here in Arizona with some of the radio leaders. And with that, we have been expanding our outreach to this population that usually use the technology that is radio instead of social media or flyers or other things. And because they trust these speakers, they will increase their vaccinations, and that's how we are spreading the word on how to get vaccine, for example, in some of the areas in Phoenix. In the next slide. And very important is to have a clear message, and I put this as an example from Valle del Sol Clinic. So basically, demystifying what they are believing. So on the left side, you can see what is a myth and then what is the reality, but talking in their own language, in their own culture, is very, very important for the Latino community. Next slide. Another thing that is important is to get involved the church. For the Latino community, church is very, very important. There was one event that happened last week where there was something that was misinformation. Thank God at the end, the entire Catholic Church in the US become united and then demystify that. So it's very important sometimes that, and I put this because if these are people that are following any religion and they are paying attention a lot to the religion leaders, we have to sometimes overcome that barrier, because sometimes those religion leaders are not well versed on this topic, and sometimes we have to involve them so they can be part of the solution. And next slide. And I mentioned this last time and I wanted to bring it again because the message is very important. It have to be a family-oriented message that have in a short time that demystify and then eliminate misconceptions. We have to mention that the vaccine protect both healthy and high-risk individuals, and that many of this study has been done in Latinx population. So there is a well-done study on this. They have participation of Latinx population, and definitely that we did it, that we got the vaccine to help, and then that we recommend the vaccine to them. So for them also, besides the priest, the healthcare worker, the physician is very important. So they will trust you if you provide a very good message. And finally, the next slide. I think that some of the recommendations is definitely we need the government involvement, because the guidelines always come first in English and then it takes 3 or 4 weeks to come in Spanish. So this need to be, the delay have to be less. So they need to be, for one of the things was the web page in Arizona for the vaccine information was in English until 3 weeks ago. So we need local and a national government involved on this. We need to also involve the health industry to make this, so when there is other things, not for the vaccine, but when there is some events, so the co-pays and all of that is very clear. The healthcare systems that we are going to talk about later about that, and the communities in total. So my last slide is that this is not only a physical problem. If you can go to the next slide. This is a problem that involves social issues, and community should be involved. And something that we have seen is that the increase on vaccination rate has been more when we start doing this in community clinics. And these are an example of several community clinics from the area where the Hispanic population go, trust, they are not afraid. And then even the religious people are doing it, so they also believe more. So this is not a problem of just the medicine, but it's a thing that we need to get engaged the community on it. Thank you.
Good afternoon, everyone. Now that you've heard from my esteemed colleagues regarding specific suggestions for various different communities, I'd like to switch gears and turn our attention to what medical schools and medical educators are doing to address disparities and to also address vaccine hesitancy. Next slide, please. These efforts really fall around three major areas. One is around education of the healthcare workforce. One is around increasing the diversity and representation of the healthcare workforce. And finally, around opportunity. And that we don't just want people of diverse backgrounds to be in the workforce, we want them to be leaders, and we want them to have a seat at the table when decisions get made. Next slide, please. So one of the major things that many medical schools are doing is to try to increase the diversity of the workforce. At our first panel, we talked about the importance of diversity of the healthcare workforce, and then Dr. Delpino Jones also talked about how important it is to have more diversity in healthcare workforce in order to improve access to care and also improve quality of care. And so many medical schools are doing outreach in order to develop interest amongst younger students in careers in medicine and healthcare. They're also building pipeline programs to try to help these students be prepared so that they are successful when they apply to medical school. There's a specific initiative currently to address the number of or the paucity of Black men in medicine, and it's called Black Men in White Coats. We know, unfortunately, that there are just as many Black men in medicine today as there were 50 years ago, even though there are so many more medical schools and spots in those medical schools. Some medical schools are partnering with historically Black colleges and universities, Hispanic serving institutions, and minority serving institutions, also around recruiting and pipeline and partnership efforts. Many medical schools are using holistic review to have balanced consideration of attributes and competencies and experiences, in addition to the traditional metrics that typically get used. Many schools are having second look events, for example, for residency applicants, a lot of scholarships or fundraising for students who are underrepresented in medicine. We know that mentoring is really important, not just to get students into medicine, but to keep them and retain them and make sure that they are successful and thriving and that they graduate. Many medical schools, kind of knowing that implicit bias can affect decision-making, are doing implicit bias training for admissions committee members as well as for search committee members. And then many medical schools track data. We look to see the proportion of people who apply, out of those who gets an offer, who gets an interview, and then who stays. And then who graduates, who advances with faculty. And then we also, many of us do climate surveys to look at how people are feeling about the sense of inclusion and equity, because diversity is not the only thing that matters. It's sort of the minimum that matters. Once people are there, we want to make sure that people are thriving and doing well and that they're successful. And then there's a wonderful organization called BINGAP, Building the Next Generation of Academic Physicians. And this is a national organization that has chapters in many medical schools, really trying to increase the diversity of the population of students who go into faculty positions in medicine. Next slide, please. In addition to trying to increase the diversity of the workforce, we also want to increase the cultural humility of the existing workforce. And so many medical schools are doing assessments of implicit bias for medical students and residents, and also doing training to mitigate biases. We do this at the University of Nevada, Reno School of Medicine. It's embedded into the curriculum, and so it's mandatory. Students get this training across their 4 years of medical school. Many schools are doing very specific diversity and anti-racism curricula. There are a lot of community engagement programs, getting students kind of out into the community, partnering with community organizations to see firsthand and address and learn how to provide culturally humble and competent care to populations that are served in the communities that the medical schools are in. Also, many of us do all kinds of trainings, safe zone trainings, microaggressions, and bystander intervention trainings. At our institution, we have monthly diversity dialogues, which is just an open space that people can come and talk about issues related to bias and racism and sexism and heteronormativity and all those kinds of things. We also, many of us do healthcare disparity forums or health equity grand rounds. And then most of our schools have affinity groups for our students and residents, groups such as the Student National Medical Association, the Latino Medical Student Association, and the rest of the alphabet soup here. Next slide, please. In terms of patient care, how are we teaching our students, and how are we, many medical schools also are academic health centers, so they provide care to the community. And so we want to increase access to care, again, knowing that certain populations experience limitations in their access to care. And so many schools have a student outreach clinic or rural clinics or satellite clinics that are specifically housed in communities where there may be more minoritized populations. Remember the importance that my colleagues talked about of not waiting for these communities to come to us, but going out to them. Also, telemedicine visits can help to mitigate obstacles to physically coming in for healthcare, particularly when there was more of a lockdown for COVID-19. And then partnering with community groups, including, as many of my colleagues talked about, church groups and other community organizations. And then also in terms of patient care, one way to reduce implicit bias in healthcare is to use treatment guidelines that are evidence-based and standardized, so that we're not differentially treating different groups of people, but we're providing the best care for all populations. And then finally, tailoring care to known needs of various different communities. And many of my colleagues talked about specific ways that you could do that as well. Next slide, please. Again, many of my colleagues talked about the importance of having culturally sensitive patient education materials that are linguistically appropriate, having initiatives around increasing and improving patient care, also building workforce that reflects the diversity of the patients that are served in the communities, including linguistically appropriate services and bicultural staff and providers. And then having relationship-centered communication for physicians. At our medical school, we have a scholarly concentration in medical social justice that I'm so proud of. They go out into the communities and they are using principles of public health to really engage those communities. And one of the things they're working on currently with our Latinx population in Reno is applying principles of motivational interviewing to address vaccine hesitancy. Next slide, please. In terms of research, this is another area that many medical schools really have this as part of their mission. And so obviously addressing healthcare disparities in our research. At UNR, we have a community of bilingual and English-Spanish speakers. That's a research initiative. I lead an implicit bias research group at our institution, and many other medical schools do similar types of research in implicit and explicit bias. Many schools have a Latino research center or a Hispanic center of excellence, which is another way of really focusing your research efforts on the communities that you serve. There's a lot of pilot funding for research. And then my colleague, Dr. Moreno, is going to talk about the All of Us research project that is happening through a UA and Banner grant. And then finally, there are other initiatives, the INBRE and the CTRIN. Next slide, please. And I will turn it over to my colleague, Dr. Moreno.
Okay, thank you, Dr. Jacobs. Can people hear me okay?
Yes.
He's going to say yes. So thank you, Dr. Romero-Leggett. It's a pleasure to be here with everybody. What a stellar group of presenters. I'm hoping to be able to quickly give you a bit of an overview about some recommendations related to systemic racism and some of the approaches that we may be using in the area of academic health and involving education and healthcare and health research to better serve the needs of the communities that have been most impacted by this health disadvantages. So that's a picture of myself. Of course, I always like to cover as much of my face as possible. I think I look a little bit better that way. Getting the shot. So, whenever you have an opportunity to share yourself getting the shot in others, I think that's also important. It communicates to others about us being part of a common struggle. This is an issue that we are sharing as a community of providers, a community of members of the population. and we're in it together type of message that always we need to be leading with as part of a team, as part of a group. Let's see the next slide, please. I'll share. Then again, I like the Nicholas Copernicus model of the solar system, in which a lot of the problems that are both sustaining but deriving from racism continue to be really, really patent. So when we think of systemic racism or institutional racism, for those of us that are at a university or a healthcare system, we ought to be thinking not of something that happens somewhere else, but of something that is really happening at our house, at our place of work. And systemic racism or institutional racism is subtle. It's normal. We don't see it as much. Once your antennas learn to detect it, they do, and maybe others that do not detect it may believe that you have too much of a signal bias going on. But I'll tell you, those of us at this session are probably really involved with health and with education. Every single sphere here is very, very relevant. But as it pertains to racism, let's just think about our own institutions and how we have not been really trained to look for the racism, and how important it is to be really able to see it, to name it, to talk about it, and to target it so that we can go after it as a way of really be better able to address the health inequities and everything that we're seeing playing out as much as it is right now. We all have an opportunity to do something. A colleague of mine, Dr. Sofia Ramos, who's much of an advocate as well, shared with me a paper from the Chronicle on Higher Education about institutional racism a couple of years ago. And as I was reading through it, it say, if at your institution you have this, you may be in a system that is racist. It reminded me of this Southern comedian that says, you might be a redneck. If this happens, or if your house this, you might be a redneck. So it reminded me of that. And surprising to me, I used that exercise to look at the hospital that we're at, to look at the practice that we're at, to look at the institution that I work at, and to also look at my own personal life. And one has to be really humble and brave when you're really looking at things that are really directly impacting you. Because when you look around and you don't see that diversity, when buildings are erected and they don't have the name of people that reflect the community, when the pictures that are hung in the walls and the art does not really reflect the community, or your own membership to these elements, when the leadership of the organization doesn't really reflect the community, when the people that do some of the lower paying jobs or some of the less trained opportunities look very different to than the people that are signing the checks or the people that are really leading. We know that we are in a situation where structural racism has taken grasp. So again, let's be brave, let's take a look, and let's do something with it. We have to be well trained, and we need to do it together, and we need to make sure that this is coordinated in a way that makes sense. When we're dealing with racism, again, we have to be also using an equity lens. It is not about what a specific goal outside of equity. It has to be driven, and that's one of the reasons why so many of our organizations and the offices that work on diversity and inclusion have really included equity so much into our names. We're putting the name forward because that has to, it's an important part of our mission. So let's see the next slide, please. Here are some recommendations for community, for institutions, and for individuals. And sometimes we're all the same, so it depends on what hat you're wearing. Let's be thinking of when does this apply to us? There's extra burden placed on individuals of color, to address a lot of these issues. So we all need to make sure that we are coming together as ally, regardless of our identity and our backgrounds, to make sure that we're really moving this agenda forward. And so it's not a thing they do, it has to be a thing we all do. So we need to feel that call and get involved and take on the burden, take on the leadership, be the one that is volunteering or donating. We're talking about COVID-19 vaccination hesitancy, and what else are we doing? So did you sign up to volunteer already? Have you gotten yourself approved to be a volunteer? Are you dedicating some hours for that? How much are we all doing this types of thing? And it doesn't have to be for a direct benefit to us. Again, it has to be in the benefit of equity. These are important pieces to talk about. I remember a couple of years ago, we had a leader from AANC, a friend of us that came to speak about racism in medicine. And it was something that raised a lot of hairs on the back of people's neck. A couple of years ago, we really were not talking about racism. It was like moving the fire to kind of smell more trouble. And so this has to be a thing that we talk about. And we need to know that this is something that we are living with very much all of the time. So let's see the next slide, please. So for the institutions, we shared how our mission is to really increase the diversity of the workforce at all levels. Of course, we need to really work on the pipeline and really also facilitate those gates to make sure that we are allowing people in that are having holistic benefit to the mission of our colleges. It doesn't have to be looking uniquely at some of those traditional academic metrics that are, of course, very important, but also are very highly predictive of income and zip code, which is part of the institutional racism in education that we perpetuate if we just look at those unique markers of performance, because they're not measuring the performance of one individual, but a tradition of series of institutional decisions that have been put into place for generations. Of course, we have to make sure that we address the social determinants of health, that we advocate for patients, and that we are really looking at what are the policies of our institution that need to be modified in order to lead to equity. It's not about fixing something that sounds funny, but it's something that needs to have an end to it. I talked to my team about how our flavor of inclusive excellence is equity. You know, it's not good enough to have inclusive excellence if it is not resulting in that advancement of equity. So, you know, we name it, it has to be part of our goal plans, and it's something that we pride ourselves in, and we're very transparent about this work. Let's see the next slide. So for the individual, we always talk about the individual. If we follow that community-based participatory research model, we know that the individual is really placed in the context of interpersonal interactions, part of a community and a larger societal aspect. Anything we do is not just something that we're going to do in a vacuum. So making sure that we are training ourselves to be better able to recognize our own biases, and also make a commitment to pursue egalitarian goals. If we are very aware of biases and we don't have a commitment to doing something that will result in equity, we're doing part of the work. Always it's good to make advances, and moving forward, again, keep an eye on that equity is the result of a series of changes that we need to be instituting in order to get there. There have been a few other recommendations that some of my colleagues have shared, so I'm not going to be duplicative and repeat many of them, other than to say it makes a lot of sense to make sure that we are partnering with individuals when we're talking about interventions for hesitancy or trust. to use motivational interviewing techniques makes a lot of sense. I'm a psychiatrist, so what that does is it really empowers the individual to find within their own perception of what their needs and priorities are a motivation for their behavioral change. And of course, we want to make sure that we are able to understand those individuals, that we validate their perspective and their knowledge, because we all have a different formative experience that have led to where we are right now. So let's see the next slide, please. A couple of important points that I wanted to share. I like trauma-informed care. This may be a new term for some of you, but not for many of you, I would imagine. Start talking about racial trauma. So many of us have learned a lot about racism and how that's a social determinant, a determinant of health, and a determinant of many other things, of course. But when you have exposure to racism, something that keeps coming back, and is usually in the context of multiple occurrences, and it's also in the context of a variety of different, not only instances, but the different contextual experiences that we're having. It becomes something that is really traumatic. It's something that affects an individual's physical and emotional health, and of course, our capacity to function. And this is something that has been well explored in education and continues to be well explored in the treatment of mental health and substance use disorder. SAMHSA has been promoting the model of actually using trauma-informed care. And this is something that has been utilized a lot more in education and health than in many other areas. We also like to think about this approach. It's a complex interaction of bringing in a lot of multiple variables, such as cultural humility, working from the perspective that the individual is the one that understands their experience, and we may not be an expert on the experience of the individuals that we're working with. So we need to partner with them in order to better understand what they are perceiving. When it comes to COVID-19, behaviors that help us protect ourselves and other community members from COVID, or behaviors that put us at risk, are many times explained by a lot of social, economic, and cultural factors as well. And so understanding them without judging them, it's a very important first step that is required in order for us to lay the foundation so that we can have our own interventions. We need to create a safe place. And what is safe to me as a provider or somebody who understands how vaccines work or how treatments work may be very different to what my patient or a member of my community may think. And when I say member of my community, it's not those people out there, but rather my parents, my siblings, people that are very, very close to us in our community. And so being transparent and trustworthy, and that means being predictable, knowing that people can count on you when you're engaging with the community to make sure that you are a credible person that has maintained a relationship that can be predicted, and that you have a reputation for serving the needs of these groups. We have injured the trust of many communities, as Dr. Dinesh Chacon gave the painful and wonderful, very recent example of our universities who had really betrayed the trust of our research participants. It's something that is very difficult to come back from and requires a lot of long-term partnerships, again, to be able to build on that. And so we must have that empowerment of the individual without going through the rest of the variables here for the interest of time. It has to be allowing the individuals to be making the decision. Our goal should always, of course, be to support people making informed, reasonable decisions. And many times those may not be obtained on the first interaction that we have with somebody. This has to be part of a process in which we engage and support folks as they make decisions. Let's go to the next slide, please. I'll mention briefly a couple of things here. These slides are going to be available for those of you that are interested in seeing. This is a very busy slide. I really like this slide because it tells us what a non-trauma informed approach does and what a trauma informed approach is like. And I'd like for everybody to have an opportunity to read this. So please look at it. This is something that we took out of California Initiative for Education that really fits well with healthcare. And I do my best to really try to promote this model. People from disadvantaged communities are a lot more likely to have been exposed to life adversity since early in life and to be currently exposed to a larger amount of stressors. This is not a secret for anybody. But when we recognize that a lot of the communities that are most disadvantaged have been traumatized and continue to be traumatized, one of the first things we have to do is make sure we do not become part of that machinery that continues the trauma. And we stop the traumatization. And when we become, as physicians, coming hard on, oh, you have to get your vaccine and come from this sort of top-down unidirectional mandate to our patients, we are sort of perpetuating that kind of relationship that triggers responses of rejection, fear, and lack of trust. So whatever we can do to make sure that we are really partnering, empowering, sharing power with, that we really recognize our goal as being that of respectfully informing and partnering with the individual. It's something that we all need to be looking for. So let's see the next slide, please. The next three slides are briefly a couple of examples of initiatives we have been involved with through some of our community efforts as well. This is the COVID-related health disparities. The Community Engagement Alliance seal, and you can see the link here in the bottom. This address has a lot of really good materials in Spanish, in English, that are available to share, whether you're a healthcare provider or a health system person or a consumer of health or an individual who's interested in learning more about it or sharing with your communities. This is definitely a page to go. There's a large collaborative around the country with 11 different state efforts in Arizona, the universities of Northern Arizona, Arizona State University, and Mayo Clinic partner with the University of Arizona as well to make sure that we help address the needs of all communities, utilizing, of course, tribal consultation, respectful engagement with the various communities, creating research experiences and focus groups and survey type of work and community dissemination and implementation that best addresses the needs as identified by community members. So this is a good example of how we want to continue to move forward in support of the communities by being informed by the communities as well. This is the next one, please. Very briefly, the All of Us Research Program is the largest platform for research in precision medicine that has been developed in the United States and anywhere else in the world. Our target is to recruit 1 million individuals. As of now, there's more than a quarter of the way completed on the recruitment, and the diversity of individuals is really superb. It's like nothing else I've ever known about or been part of, with more than 80% of the individuals who are enrolled in the All of Us Research Program being members of an underrepresented group in biomedical research. And 50+%, like 52%, are members of a racial or ethnic group underrepresented in biomedical research. So when the opportunity came to start asking questions about COVID, whether it has to do with biomarkers associated with it, or the trajectory of COVID before we even knew we had COVID, or the behavioral responses to COVID, having this platform of several hundreds of thousands of people in the United States that have been part of this initiative really created a very nice opportunity. So my colleague, Dr. Jacobs, mentioned here in Arizona, Banner and the University of Arizona are one of the health provider organizations that are participating in this type of research. This is available all over the country for folks that want to participate as direct volunteers as well, and they have an opportunity to do that and promote participation of groups underrepresented. And the last one, last slide. This is an initiative of advancing the training of researchers. So for those of you that are perhaps working in the clinical arena or educational arena and want to be involved in research, here's an opportunity for early career researchers to participate in training that will allow them to be successful researchers to improve health disparities. And this year in particular, we have a special focus on providing training to people that want to do COVID-19 related research. So I'll leave it right there. I know that we're running short of time for our Q&A. So Dr. Romero-Lega, please.
No, thank you so much, Dr. Moreno, and to all of these esteemed panelists. My goodness, just this critical information that we know is extremely relevant to what we're experiencing in our communities and that we're personally experiencing. I really appreciate the sharing of the data and the narratives and these strategies to address the disparities. And I really appreciate, Dr. Moreno, as you said, like we talk about our communities and populations, and it's all of us. We're in this together and hoping to, again, to support people in making these informed decisions. So next slide, please. I just want to make note that we all know that these sessions are collective efforts and many behind the scenes doing so much to ensure that these are coordinated, successful webinars. So thank you to Chris Martin in our telemedicine and Ali Joseph in coordinating all of this for us and making sure that everything went smoothly today. And Meg Alcock for that beautiful flyer you saw, and Dr. Carrillo for getting the CME together for the University of Arizona. Just make note that you can access both part 1 and part 2, the recordings and the slides at this link, and the link will also be in the chat as well. And next slide, please. Just a final reminder for your CME credit for the University of Arizona using the QR code and the link as well, and you'll be asked to complete a survey. And next slide is getting us into our Q&A session and joining our panelists today, some of our other collaborators from the Southwest DEI Collaborative who have been vital to all of these webinars. So Ana Yancy Lombardero, Dr. Lombardero is the Assistant Professor of Psychiatry, Behavioral Sciences, University of Nevada, Reno, School of Medicine, and Francisco Lucio is Associate Dean, JD Francisco Lucio. I keep saying everybody, doctor, and you are a doctor, a JD, doctorate, Associate Dean, Equity, Diversity, and Inclusion, University of Arizona College of Medicine, Phoenix, and Valerie Madera Garcia, who is a doctoral student at the University of Arizona Mel and Enid Zuckerman College of Public Health, Victoria Moraine, who is family physician and vice dean for DEI, University of Arizona College of Medicine, Tucson. And unfortunately, Dr. Jose Rodriguez couldn't join us today, but he's Associate Vice President for Health Equity, Diversity, and Inclusion and Professor in Family and Preventative Medicine at University of Utah School of Medicine. So now, please open this up for discussion and questions in your chat. Just please place them there. And one thing I know, there was a question before by Maria Bala, and I would like to just read the question, but then for those who may not have been able to see the question before with different things going through the chat, if it was for Dr. Delfino Jones, and the question was, in addition to practitioners directing patients to the vaccination events, what were other ways that you spread the word about the vaccination events to increase attendance and the use? e.g., how did community centers get the word out about the availability of these services? So Dr. Del Pino Jones, would you please go ahead and respond and just verbally here? I know there was something in the chat. Thank you.
Sure. Yeah, so, you know, a lot of the communications have taken place, I'd say via social media. And as you can imagine, the leadership at the churches have their congregation, and there's been a lot of just word of mouth as well. I've actually been really surprised at how much has been through word of mouth. We have a number of other community organizations who hear about the different vaccination events at the churches. So we have our Mile High Medical Society, which is a group of physicians and other healthcare workers, so African-American physicians and healthcare workers who have also helped call different people, have created flyers with the information so that other physicians could actually share that with their patients as well. So yeah, I was thinking about it. My mom actually heard about one of the church vaccination events through a friend who is a member of that church. So that's why I say I think there's a lot of word of mouth as well.
Thank you very much, Dr. Del Pino Jones. And I'm looking to see if we have a couple of the questions here. And in the meantime, does anyone here have anything they'd like to add or comment about from today's session?
Yeah, I would just want to just give an example at the College of Medicine Phoenix. We've partnered with the local Maricopa County Department of Health and other organizations to recruit our students and our residents and our faculty to engage with community members through community organizations for the educational interventions that you all heard about. But it really is a way for us to galvanize, I think, the eager support that we have in particular from our medical students who want to go out and want to help to address vaccine hesitancy. And so this is something that we're engaging in, and just a way to kind of create space to tap into the expertise that folks have, and an opportunity to kind of just bridge with the community. So that's another additional example of something that we're doing here locally, as well as the hosting of a listening session that we'll have later on in the month with collaboration with faith-based organizations, as others have mentioned, something that's important. So yeah, I think a lot of permutations out there of what we can do and what might fit best with your local community.
Thank you very much, Dr. Lucio. Really appreciate that, and just sharing some other strategies for us today. What about any others of our members? If you have anything else right now that you'd like to share, I'm looking through and just kind of checking the chat out while you all offer some other words.
I'd like to expand part of the comments that Dr. Correa was making in terms of how, when the vaccination started, it all rolled out digitally. The authorities have been responsive to the fact that individuals from underrepresented groups, Latino communities, African American communities, Native American members may also, especially in certain age groups, less comfortable with the use of the technology that have been required for that, and also having the time for that. So, there's more advocacy, there's more response, there's phone lines, there's Spanish language phone lines, but we're sort of retrofitting what we're doing to try to catch up and minimize those disparities. So that's going to be the name of the game for us, to stay on our toes, continue to speak with the leadership and coordinate some of these efforts. There has been, of course, very nice responsiveness from the authorities. This, of course, varies from county to county and state to state. but people do listen when providers, when community members are advocating. We have, I think, right now a fertile ground for good collaboration. So your voice gets good echo and gets good actions in response to it. Let's continue to do that together.
And I want to add to Dr. Moreno. It's something that have been, as I mentioned in the lecture, is partnering not only with partnering, for example, partnering with artists, like local artists from the area, and show them that those artists that they can go and paint the day that the vaccination is, attract more people, for example, in the Hispanic community. This very successful. There's a YouTube video that I don't know if that's released yet, but in California, they did this in LA, very successful. We are trying to do this in Phoenix with Frida's Garden. There is a place where the local artists go and paint, and then that attract a lot of the community. So that's you go 2 for 1. You get the vaccine, and then also you get to see artists and art. So that's good.
Love that idea. That's great. And Dr. Moraine, Valerie, and Dr. Lombardero, anything you'd like to?
Dr. Moraine?
Sorry about that. At the College of Medicine in Tucson, we're actually doing similar things with having our students, faculty, and residents volunteer, but we also have one of our immunobiologists, African-American male, who has organized a group of scientists across the country, faith-based, who are going to African-American churches and presenting this information so that you level that playing field and you are able to answer the questions from experts who look like you.
Yes, in the Phoenix area, also a collaboration between Mayo Clinic, Dr. Angela Allen from Banner as well, have been reaching out to through churches, also to members of the African American community, and with very good responses and good engagement.
I would like to share that just in this past week now, our New Mexico Department of Health, who has Dr. Collins as our Secretary of Health and Dr. Parajon as our Deputy Secretary, have just recently rolled off, and like fresh off the presses, but of course in weeks and months of preparation, our New Mexico Vaccine Equity Plan. And the name of it and the tagline is putting equity at the center of New Mexico COVID vaccination program. And they really wanted to be very intentional about that, instead of, again, as we all know, a lot of times things are just on the periphery and here and there, and maybe not seen as important. So this, I would please, and I'll see if I can find it and put the link in the chat, because I think it's something, again, that speaks to all of our communities, especially our communities of color and our communities that are disparately affected at this point in time, and has, I think, some great things to offer all of us, just as today's presentation and the part 1 presentation did as well. So just really want to thank everybody for joining us here today and staying with us for this hour-and-a-half, like very informative session. And we'll look forward to being back as a Southwest DEI collaborative with some other webinars or sessions with all of you. But just very deeply heartfelt thanks to the collaborative and everyone who has been a part of this, and all of you who have joined us and are doing things each and every day to make a difference in your communities, in your institutions. So thank you for joining us. And remember, you can see the recordings and the slides on the link that was sent, and we'll see if we can send that out as well afterwards. So thank you for joining us, and everyone have a wonderful day.
Thank you, Dr. Marilega. Great work at leading us.
Thank you.